Welcome all to this week's IAP's clinical club, and IAP Kozhikode is very happy to chair uh, this week's clinical club, uh, PG club, and this week's our speak, speaker is main is Krishna sir, and the case will be discussed by Dr. Navi. I request Mohandas sir, then our PG club coordinator, to uh, say a few words.
Good evening, respected senior colleagues, Dr. Sindhu, President IAP Calicut, Dr. Ananda Keshavan, Scientific Convener of PG Club, Darli Madam, Dr. Jose, Purushothaman Sir, Dr. Latika, and all other colleagues and postgraduates. So this week, IAP Calicut is hosting the PG Club, and the zonal coordinator is Dr. Aslam, who has done his job well. And today's mentor is Dr. Sabil Abdullah, who and the case is being presented by Dr. Naveen, the JR3 of Calicut Medical College. And today's discussant is Dr. Krishnan, Professor of Pediatrics, Government Medical College, Kozhikode. And he's also in charge of our pediatric nephrology clinic. So I'm very happy to be part of this program. And I would like to welcome Ananda Keshavan sir to say a few words, who is the scientific convener of this program.
Very good evening, respected branch president Dr. Sindhu, program coordinator Dr. Mohandas sir, my classmate, I think my classmate also, my person from Kannur district, Dr. Krishnan, is my classmate. And my teachers, Dr. Purushothaman sir, Sushma madam, my dear friends, Jose, all other senior members, my students. So it is another very attractive program by IAP Kerala Presidential Action Plan. And every time we are getting new and new cases and different types of discussion. I'm very happy to see that Bhushan sir is actively participating, and Sushma madam also almost all program, madam also attending this program. So in short, I think it's meant for both the students and the senior colleagues also. I wish the program all success. Thank you. Jai Hind, Jai IAP.
Hello. Hello. Dr. Sabil. Sabil undo?
Yes, sir. Yes.
Sabil, do you want to? You can introduce the today's faculty, and also if you want to say anything about the case.
Okay, sir. So.
Sabil, connection കുറവാന്ന് തോന്നുന്നു, ക്ലിയർ ആവുന്നില്ല. Sabil, ഇവിടെ റേഞ്ച് കുറവാണെന്ന് തോന്നുന്നു. It's okay. I think I have already introduced Dr. Krishnan.
Okay, sir.
I think we can start the program.
Okay, sir. Okay.
Okay. Now we are ready, alarm.
Okay, sir.
Okay, wait. Before that, I will just thank AP Kerala for giving me this chance for this addressing to participate in this program, prestigious program. And happy and bit nervous to lead a discussion in front of senior faculty. So I am happy also that they will be also contributing in the discussion. So this okay. I think we can start with these words.
Okay, sir.
Now we can start.
Good evening, all. We'll be discussing a case of an 3-month-old male child who is coming from Chemmad, Malappuram, and the informant is mother, and the history is reliable. The presenting complaint was bending of both knees since 1.5 years of age. History of present illness. Apparently normal child with a history of seizure episode at neonatal period was noted to have significant bowing of both the lower limbs 7 years back. Child had difficulty in walking with abnormal position of the legs during walking. The left leg, as noticed by the mother, was bent inwards at the knee more as compared to the right. Child was initially consulted to hospital at 3 years of age. Blood investigations and x-rays were done and started on some oral sachet which was given weekly once for initial 6 weeks, and then it was given monthly for around 1 year. Child was followed up with investigations and was added on another oral medication as the complaints persisted. Since 2 years of age, child had multiple fractures with minor trauma, left wrist at 2 years, left elbow at 3 years, and right elbow at 4 years, all managed conservatively with plaster cast. At 4 years of age, mother noticed that the child had widening of the wrist joint of both hands. At 5 years, she was consulted to IMCH with the complaints of this increase in bowing of legs and abnormality in walking. Child was noted to have multiple abnormalities involving the head, chest, and wrist, and was extensively evaluated, and was started on oral medications with 2 solutions and 1 capsule, and was regularly followed up since then. No history of any generalized weakness, abdominal distension, no history of any headache or vomiting or photophobia noted by the mother. No further seizure episodes were noted. No history of any significant increase in head size noted by the mother. No history of any stridor or abnormal hand posturing. There was history of delay in secondary dentition, which upper incisors as per the mother, and history of dental caries are present. No history of any chronic medication use or recurrent abdominal symptoms. No loose stools or oily stools as per the mother. No history of any frothing of urine, blood in urine, or increased frequency of urination or poor urine stream. No history of any recurrent urinary tract or respiratory infections as per the mother. Coming to the past history, child was active and feeding well at home till 3 months of age. EEG for seizure at the neonatal period was done at 3 months, which was said to be normal, and then parents stopped the medications by themselves. Vitamin drops were given only up to 3 months. No history of any other chronic medication intake or alopecia. And antenatal, natal, and postnatal history. This is the first child of non-consanguineous marriage with an uneventful antenatal period and normal antenatal scans. It was a term normal vaginal delivery with a birth weight of 2.915 kg, and the child cried soon after birth. Child was admitted in NICU in view of abnormal posturing of the left hand noted on the day 1, for which blood investigations were done and which was said to be normal. Child was given IV medication for 7 days and was started on oral medications on discharge on day 8. At discharge, child was active and feeding well with no further episodes noted. No history of any hypoglycemia or jaundice noted at that time. Developmentally, child attained all age-appropriate milestones in all domains, and hearing and vision is said to be normal. Immunization, 5-year vaccine is pending for the child. No history of any adverse events following immunization, and no additional vaccines are taken, and the BCG scar is present. In the dietary history, there is a deficit of 440 kilocalories per day, and protein is adequate for the age. And child was exclusively breastfed till 6 months of age and was started complementary feeding with ragi. There is a history of less consumption of green leafy vegetables, fish and eggs. And the child consumes milk adequately and occasionally consumes chicken and seasonal fruits. No food taboos or allergy as per the mother. And this is the family history. There is a non-consanguineous marriage and the sibling is not affected. No history of any short stature, renal disease or seizures in the family. No history of any abortions or early neonatal deaths or infantile deaths in the family. No bowing of legs or in the family members as per the mother. Socioeconomic, they belong to a lower middle class family along with the modified Kuppasamy scale. Now, summarizing the history, this is an 8-year or 3-month-old child, developmentally normal child, first born out of a non-consanguineous marriage, presented with bowing of the lower limbs for a total duration of 7 years. There is history of multiple fractures, delayed teeth eruption, and poor response to the initial treatment as per the mother.
You presented the history very well. So you summarized also. So 8-year-old presented non-consanguineous parents presented with the boy. Noticed that the what age?
1.5 years of age.
Boeing was 1.5 years. That is one point you could have added in the summary. So Boeing lux notice is 1.5 years, which is now even persisting.
Yes, sir. It is persisting.
Even persisting now. So
Yes.
that is the history, main thing in the history, isn't it? Okay, so I think we can just from the history, what is the most likely that is having? What is the most important problem that is? What do you think that is having?
It could
For
be
non-consanguineous parents with identified normal, you told.
yes, sir.
With birth weight also normal, and
Yes.
noticed deformities,
Yes.
1.5 years. Now
Yes.
persisting. Okay.
Yes.
So what is the most likely that is having?
According to the deformities, it could be it is mostly affecting the lower limbs with the bowing of the limbs, and there is also history of dental caries and secondary eruption of teeth, and
Okay.
possibly
So what is the deformity due to? That is the first thing you attend to that. So what is the deformity? What is the cause for deformities?
it could be
What is it?
possibly
And there's fractures also. And fractures also.
yes, sir. It could be
So
possibly
usually case will be this type of case will be kept as a short case. So that is we can discuss like this rather than going into each and each steps.
Okay.
So that's why I am discussing like this. Okay. So what is the cause for deformities and fractures? Do you think?
It could be rickets, sir, possibly due to
Rickets. Okay.
deficiency.
Okay. This studies have rickets. Any other possibilities of any other reason for deformities do you consider? Did you consider or are you considering other than rickets?
No.
There are other causes of long-term deformities of the extremities or body other than rickets?
Can be like osteogenesis imperfecta, conditions like
Okay.
osteogenesis imperfecta.
Okay. So there is a multiple fractures. Okay. Anything else? Any systemic disease?
Could be renal tubular acidosis.
No, that's also rickets, isn't it? Any other than the rickets and the primary bone disease? Any other possibility? Any systemic disease? Suppose you may get some organomegaly also. Suppose you are getting. Can it be due to any
storage disorders and
storage disorder? Is it do you consider that also as a deformity? Can cause, isn't it?
yes.
Okay. So do you consider that also one of the DD now after from the history?
There is no history of
You haven't examined. We haven't examined it.
yes, sir. There is, but there is no history of consanguinity and.
Okay, so so before going to the discussing each DD, so these are broadly you can consider these possibilities. One is rickets, then some dysplasias like due to either storage or primary dysplasia of the bone. Also, you can consider in this after hearing the history before going to examination. Okay, okay. So you among this you consider which one first?
Rickets, sir, possibly.
Okay. So what type rickets? Any other specification you would like to add to rickets?
It could be possibly a refractory rickets because the child had received.
Refractory rickets. Okay. So why do you say this child have a refractory rickets? So you can go to the previous history, initial stages. First slide. So why do you mention this child is having a refractory?
Because the child had initially consulted for the complaints and was given medication for around 1 year. And
okay,
following
they received medication. What type of medication you have specified? Did you specify? You have specified. What type of medication?
It was an oral sachet which was given weekly for
sachet. Probably
vitamin D
sachet could be vitamin D. So this child probably received vitamin D sachet multiple doses, almost 1 year period. So that's why you are telling that this could be a refractory rickets. Okay.
Yes, sir.
So most likely. Okay. So what is the definition of? Can you give when will you say that the child is having refractory rickets?
When there is
when there is no healing.
Healing as when after initiation of treatment, and when there is failure to therapy noted after 2 doses of vitamin supplementation.
No, it's not supplementation. It's a therapeutic dose of vitamin D.
Yes, sir.
given 2 doses, between 3 to 6 lakhs, given 2 doses, almost 4 weeks apart, not showing any evidence of healing. Okay. So what is the earliest sign of healing? So you'll be looking for a refractory recurrence. So what is the earliest sign?
There is a line of mineralization in the X-ray.
Line of calcification, isn't it? Line of calcification you will be seeing. So absence of line of calcification in the preparatory zone of calcification, if you are not seeing, identifying, you can make a diagnosis of a refractory rickets. So probably the child is having refractory rickets, isn't it?
Yes, sir.
So even after your history tells that even after giving multiple doses, child is persistently having deformities and even multiple fractures also that you have given, isn't
Yes,
it?
sir.
Okay. So